It was very important to me that I could be with Mom till the end. A lot of people get too technical and want to push away the family. And basically I felt that that was the family's decision. And Mom and I were very close. And I know that Mom would have preferred me to be there. Whether she was fully aware of what was going on or not, I still think that Mom knew whose hand she was holding. It was nice, it was a closure kind of, because you could say goodbye. I mean, even when she finally passed, and I knew everything had stopped, it was, I still kissed her on the cheek and said, goodbye, Mom.
When residents move into an assisted living community, they are usually fairly active, often able to perform some or even all of their activities of daily living. For many residents, they are leaving their own home and moving into a new, wonderful group environment. They expect to age with us, and eventually they may die with us. During today's learning experience, we are going to discuss caring for residents during the dying process. You are going to hear from experts in the field of hospice care.
When a resident has been deemed terminally ill and the doctor has given the order for hospice care, hospice comes in to help with the care of the resident, but not only the resident, the family, the caregivers, to support the whole process of the terminally ill status. Comfort measures, end-of-life issues, grief and loss issues, all those things will be looked at in the plan of care with the resident. And our job is to support the family and the caregivers to help the last days of the resident to be the most comfortable possible.
It was wonderful knowing that Mom was in a place that would get extra help and helping me. I was there with her, and I'm glad I was. But as far as turning her, keeping her bedclothes dry, the things that get very difficult at the end, it was wonderful to have help, because nobody can do that by themselves. There's just no way.
The most important thing is communication. And remember, we have a plan that we're working on together. And the plan of care is always a living, breathing thing. We are always going to make changes in it. As the resident's condition changes, the plan of care will change. And the most important thing is when there's a change in the patient's condition, give us a call. Give the hospice a call. They will act in whatever way is appropriate. The nurse will give a call to the facility, get the information of what's going on with the resident, and if the resident needs a visit, the nurse will come out and do a visit. Sometimes the problem can be handled over the phone. It might be something very minor. But communication is the key between the hospice, the caregivers, and the family.
It was wonderful. I never was in need of anything. They were very good at helping me with what I needed, what she needed. It was a family process. It wasn't just for the patient, and it was the most beautiful thing. I would recommend it to anybody that has to go through that.
When a resident and his or her family are told that the situation is in a terminal phase, when the resident has 6 months or less to live, they're looking at a whole different type of focus. They're looking at their fears. The residents and their families are fearful of the unknown. Physically, what types of changes will happen? They'll say to themselves, will it hurt? Will I have pain? Will I be weak? Will I be bedbound? Will I be in a coma? All those physical changes are very frightening. In the hospice, we come in and support the resident and the family and the caregivers to anticipate what the next step will be, to be prepared. So hopefully when these changes happen, we're ready.
When death is imminent, it can be a frightening process for us as caregivers. You may feel some hesitancy in spending time with a resident as you know death draws closer. It's important, though, that we are there to assist them with this journey. Remember, the resident is probably still very capable of hearing your sweet words. Speak in a gentle tone with the resident. Talk about pleasant things. Remind them how much you enjoy being with them. Sometimes a very gentle touch on the hand can be most reassuring. Don't be afraid to just simply be seated next to the bed. Just the fact that your presence is there can be reassuring.
From the psychosocial perspective, the resident is going through all kinds of possible fears, changes, relationships, the losses that he's feeling. We have to remember that our resident who is terminally ill, he is preparing to lose everything of this world. He is preparing to lose his family, his surroundings, his home, preparing for another world. And that leads us to the spiritual aspect, where we have our spiritual counselors, our chaplains, who work with the resident and the family and the caregivers to help prepare for the spiritual journey that the resident may have. Not everyone is interested in pursuing time with the chaplain or spiritual counselor, but hospice makes that available to all patients and their families, and to support the caregivers also.
Mom was kind of unique. There was not much spiritual change. She had stayed pretty level all the way through her life. Matter of fact, when she was younger, she was a little more rigid. And as she grew older and she became more balanced, actually, it was kind of surprising. And Mom's spirituality stayed pretty much the same, but she was very consistent with it. And we made sure that she got to see her ministers. And she kept her literature with her and her Bible, and when she didn't feel like reading herself, we would get somebody to read to her, or I would.
Probably one of the toughest things about taking care of patients who are dying is getting through the barriers of our own fears, our own anxieties, our own history. Possibly we've had a loved one pass away ourselves, and maybe it was a difficult death, or maybe it wasn't. It might have been a joyous situation. But either way, we come to the table as caregivers, as even hospice staff, with our own history of death and dying. One good way to look at it is to remember that it is the resident's journey, it's his path, and to embrace that resident helps him with his path, helps him with his death and dying to be smoother, easier, more peaceful. One of the best ways to get over the hurdle of fear of going into the room, of what's it going to be like, is to speak about it, talk about it.
If we look just at the physical component of a resident during the end of life process, we tend to look with our tasks as the priority, making sure they're clean, making sure they're hydrated, making sure that they're receiving some form of nutrition. However, there is more that we need to provide for the well-being of a resident, particularly during the dying process. We should not eliminate the fact that residents can still respond to us on some level. And although for us, we're not always sure how to measure what that response is, sometimes that close connection between caregiver and resident is really strongly felt because you know your resident so well. Don't eliminate the eye contact, and lastly, certainly don't eliminate the words and kind words and encouraging words you normally provide your resident, even when they were more alert and aware. It has been known that a resident can maintain their hearing abilities for quite a long time, even in this process. Your voice, if a resident even cannot interpret your words, could be a comforting factor to that resident because it's familiar to them.
And the hospice staff, we are there to one-to-one walk into the room with the caregiver, show them how to give personal care, show them how to turn a resident who's in his final days and he can't help turn himself in the bed, talk about, anticipate what the next step will be, physically what to expect in the resident, because as caregivers, I think sometimes the fear is the unknown also. Just as the resident and his family are fearful of the unknown, so are the caregivers. So if we update the plan of care, talk about what's next, when the resident is starting to go in a semi-coma, we'll talk about what the next step and what semi-coma means and how we can take care of the resident in that situation, in that condition. One of the most common questions hospice staff, hospice nurses especially, are asked is, how long does the resident have? What signs and symptoms will we see when the hospice resident is at end of life? And it's variable. That's the first thing we should remember, is that every person's journey may be a little different. And that's what makes hospice care so special, is that we have to always be alert and aware of what journey the resident's on and how he's doing and modify the plan of care according to his needs. But there are some general guidelines. There are some common physical signs and symptoms that we do see in end of life.
With most residents, there will come a time that they will stop eating and drinking. For some of us as care providers, that's a very frightening time. We're used to providing for our residents, encouraging our residents, and when our residents simply begin to shut down and refuse food and fluid, it can be difficult on us to watch. Remember, dehydration can be a friend to the resident, not something that we fear during those last days of death. Frankly, when the resident is dehydrated, he is often no longer vomiting and experiencing GI distress. Always encourage food and fluids as long as your resident wants to consume them, but understand there may be a point that they will refuse altogether.
The last week or so of life, just in a general way, we see where the resident will decrease his eating. He may not be eating at all, just little bites. We call it just oral gratification, maybe a little custard, maybe a little pudding, maybe a little scrambled egg, and the resident will be very uninterested in eating. And that's actually a very normal, expected end-of-life issue. The body is shutting down. What happens is each of our organs will shut down as we get closer to death. And the gastric system is one of the first to really shut down. The body can no longer digest large amounts, if any, food. So your resident will, at the very end of life, not really be able to eat at all.
It can be very upsetting to the resident's family when the resident stops eating and drinking because the family realizes that death will be imminent. Provide good oral care to your resident during this time period, keeping their lips well moistened. Make sure that you're using lotions and creams on their skin so their skin doesn't dry out. Some residents may have trouble with their eyes not being moist enough. You may ask the physician. They may wish that you use a mist in front of the eyes or drops to keep the resident comfortable.
I had heard a lot of the end stages. I had studied a lot because I worried about it. And when Mom stopped eating and drinking, it's scary. It's a normal instinct to want to try to get them to eat anything or drink anything. Or I went around looking for popsicles and Jell-O and anything that I could get wet in her mouth. You kind of panic. It's real hard not to. But I had to keep preparing myself that was her way of things slowing down. Her way of showing she was just taking her time, and that was just the way it was going to go. And you just have to, rather than keep forcing them to be alive and suffer, you just have to let them go on their own. And it's about the most difficult thing you can do in your life.
At that last week or so of life, the level of consciousness of your resident will decrease. He will be much less alert. He will be sleepy, so to speak, and really be able to be up very little, if at all. The last week of life, your resident really will be most comfortable in bed frequently. So as you see your resident decline, not interested or not really able to eat, he also will have a difficulty being awake or even tolerate sitting up for his meals. Call the hospice, have us come out. We want to make sure there are no other issues going on. We don't want to miss something that we can help keep the resident more comfortable. But that would be an expected part of end of life. So the resident at this point, going into the first week before death, is now pretty much bed-bound. Decreased level of consciousness continues each day. Your resident at this point is dependent on all of his care. He needs to be checked every hour, minimally. He needs to have his turning done for him as he gets weaker and weaker. The last few days of life, the resident will frequently be non-responsive in a coma state. And again, some residents might not be completely in a coma state, but many are. That's when they are dependent for all of their care. They will be incontinent. If they haven't already, they will be incontinent. They must be checked every hour to be sure they're clean and dry. They still need to be turned. And that is something that sometimes caregivers and families are afraid of doing. They say, we don't want to disturb mother. We don't want her turned. It'll just hurt her. And actually, she'll be more comfortable if she's turned and repositioned every hour. If she's having pain, then we will deal with the pain as a separate entity. We will deal with the pain and handle the pain. The last few days of life is when our residents need us even more. They need us to be at the bedside, turning, repositioning, giving good physical care, good oral care, good bed bath, lotion, keeping them clean, keeping their hair combed nice, all the dignity issues that we would want for our own families, and all the comfort issues that we would want for our families and ourselves.
They supported me just as much as Mom, really. The hospice is basically for the whole family unit.
One frightening end-of-life comfort issue that families and caregivers aren't sure to handle is the changes in the breathing rhythms that our residents face at end of life. All of our systems shut down when we are dying. The respiratory system is also shutting down at end of life. The last day of life, we will typically see irregular breathing. It can happen even before the last day of life. We can have something called apnea. Apnea is where the resident is breathing, and then he'll stop breathing for a certain amount of time of maybe 10, even 20 seconds, can be even longer. This could start a few days before the very last day of end of life, and that can be disturbing to caregivers and families. We have to remember that that is a normal, expected aspect of the last day or so of life, or even the last few days of life. Another type of breathing that we see at end of life, the very last day or so usually, is called Cheyne-Stokes breathing. And that is a little bit disturbing to families to see for the first time. And what it is the resident will have very rapid breaths, several very rapid breaths, and then they'll have periods of apnea. The resident will go like this. No breathing, that's the apneic period. And then he will do this again. No breathing. So you have several quick breaths and then periods of apnea, no breathing. The periods of apnea will get longer, that last day of life, 10, 20, 30 seconds. And the episodes of short breathing, short fast breathing, short quick breathing will get shorter. To at the very end of life, the resident on his very last day will eventually, the apneic periods will get very long. He'll take his very last breaths. So Cheyne-Stokes breathing with apnea is expected. It can be frightening for caregivers and families. The hospice should be called if you have any concerns that he's not comfortable, if the resident looks distressed, but that is an expected end-of-life sign and symptom. A very wet breathing, an old-fashioned term for that is called the death rattle. We don't care for that term. It's really not a very nice term, but that is what the families call it when the resident at the very last day or two of life has a very, very wet sounding breathing. It almost sounds gurgly, and it can be very disturbing to the resident's family and to the caregivers because they're concerned that the resident is suffering. The wetness, the end-of-life wetness that we hear in the respiratory system does not in any way cause any discomfort to the resident. There are things we can do, though, to lower the amount of wetness and gurgling that the resident makes. And again, this is their very last day of life usually. There are medications that the nurse can get orders for. There's a medication called Levsin. That's a little drop that the nurse can put under the tongue. And there's another medication we can get called a scopolamine patch. And it's a little patch that can be put right behind the resident's ear. And it helps dry the secretions. And it really alleviates concerns that the families may have that the resident's uncomfortable. And that's something that is perfectly normal to do. We can absolutely get that medication to help alleviate some of the wetness. Another thing that caregivers can do, is very helpful, is raise the head of the bed. If we put the head of the bed up about 30 degrees, whatever is comfortable for the resident, gravity will help drain some of the wetness, and it'll help alleviate some of the noisy breathing that the resident may have in his last day of life.
Respect and dignity are still appreciated even at the end of life by the family and, of course, your resident.
Well, the difficulty with the whole death and dying subject is that we all come to the table with our own history, our own cultures, the way we've been raised, and our own belief system. The best thing is to let the resident just say what's on his mind. Sometimes silence is okay. Sometimes when a resident just wants to talk, he's not necessarily looking for a magical answer back. He just wants to share his concerns, his fears. And that's where the hospice can really come in and help talk one-to-one with the resident, his family, and the caregivers too. Because everyone's different, everyone responds to death and dying in a different way, and the best thing we can do as caregivers is remember that it's the resident's journey he's taking, it's not our journey, and it's our job to support that journey the best we can. But the most important thing to remember as your resident is approaching end of life is that he always can hear you. And this is so important. Residents can hear us. They still enjoy our voice softly. Families can still come and sit with their loved one and talk to them and still spend time with them, spend quality time.
Mom had a pretty steady decline, but they seem to, and I've heard other people say this, that they have a kind of a wake-up point. It's like a final thing to say goodbye. They feel they have to tell you something all of a sudden that they've thought about that may have been 50 years ago. They wake up for a minute and give you this last, sometimes it's confession or just something it was very important to them they had to say, and then they go on out slowly. The last couple days, no, she got quiet. She kind of spoke to me with her eyes and the squeeze of the hand, or patting. She would pat my arms. And she did that for a period of about 2 or 3 days. And then after that, no, it was more relaxing. And I was very glad she went in her sleep. She just went out like she took a nap.
As we assist our residents during this journey, we want to make sure that we are providing the best physical care possible. In addition to assisting with fundamental activities of daily living, we also want to make sure that we know how to help our residents with some of the challenges they may face, such as nausea or vomiting or constipation or problems with pain. Let's examine some of these issues.
Nausea and vomiting. That could be something that your resident can have because of a medication that's bothering his stomach, or the disease process itself. Some diseases cause a lot of nausea, others they may not have any. Some of the ways you can help that resident with his comfort when it comes to nausea, of course, the resident will have medications ordered by the physician. That's very helpful. The medications are usually given around the clock if a resident has nausea, and it can be given by mouth if it's nausea. Sometimes, though, if vomiting occurs, the medications have to be given in another route, such as rectally. That's where the hospice needs to be called. If the medications aren't working and the resident is still with nausea, the hospice nurse needs to be called. And if the resident starts vomiting and that can't be controlled with the medication as the doctor has ordered, then the hospice needs to be called. Dietary considerations can also help control nausea, for example. A bland diet, the nurse might direct the caregiver to start the patient after vomiting has subsided on a clear liquid diet. This is something that the nurse will advise the caregiver and give guidelines throughout while we're managing the nausea and vomiting. So dietary restrictions while the resident is getting over the period of nausea and vomiting, medications, and other comfort measures that caregivers can give is, for example, oral care. Oral care is very important when a resident has nausea and or vomiting. Positioning. Sometimes if someone has nausea, they are a little more comfortable if they're laying on their side. It's variable. Some residents are more comfortable on the right side and some are more on their left. It depends on their medical condition. But sometimes laying on their side with their knees up just a little bit will help. A cool cloth on their head, a fan in the room, sometimes head of the bed up about 30 degrees or so, that can help. And then sometimes just something to get their mind off of the nausea. Maybe be sure that open a window or get some fresh air in the room, or maybe put a television show on or some light music that you know the resident would enjoy, trying to get their mind off the nausea. Any resident who is on medication for pain, such as an opiate, any of the narcotic/opiate medications, is at a very high risk for constipation. It almost goes hand in hand because one of the side effects of opiates is constipation. But it's not just the residents who are on opiate. Any resident who has a decreased mobility, has decrease in his eating or decrease in fluid intake, or is just in the process of the dying process, has a high risk for constipation. It is very important, it's imperative that caregivers and families and hospice work together to ensure that constipation does not become a problem for the resident. It will be on the plan of care, dietary issues, taking in fluids, but also medications to prevent, such as stool softeners and stimulants. So it's vitally important that if a resident has not had a bowel movement in a couple of days, that the hospice be called. We never want to go over 3 days. That's an absolute maximum. But it's vitally important that if the resident even has a change of his condition, such as a decrease in appetite, or if he has nausea or even vomiting that's unexplained otherwise, he very well might be having some problems with constipation. Even if the resident's had a small bowel movement the day before, if it was hard, pebbly, not a good healthy bowel movement, he very well could be at high risk for constipation, and that could lead to other problems too. So the caregiver should call the hospice if the resident has any abdominal discomfort, if he has a tummy ache, so to speak, he's not interested in eating, has nausea, or even has a small temperature. These could be some of the signs of constipation, but certainly if it's been greater than 2 days, they follow the plan of care, assist the resident, or the resident will take whatever medications are on the plan of care for his constipation. But if there are any problems at all, call the hospice and we'll address it directly. Skin breakdown is another major problem or potential problem for hospice residents in any setting. Their bodies are shutting down. Their skin is getting weak. They're not eating as well because they are so sick, and because they're not eating well, they don't have the protein intake, and their skin, it has a very high potential to break down. Also, if they're not drinking very well and they get a little dehydrated, they have a higher risk of breaking down, as well as a decreased mobility. So what can we do to help prevent the best we can skin breakdown and help promote comfort in our hospice residents? Well, one thing is meticulous skin care. Keeping the resident clean and dry is one of the most important things we can do. Incontinence is a major problem with terminally ill patients. They will frequently become incontinent at end of life, almost always, really. So it's very important that the caregivers meticulously keep the resident clean and dry. When you think about it, the urine is so harsh on the skin, it can really just eat at the skin. So we want to keep the resident clean and dry with proper lotions, whatever the policy of the facility may be. And again, this will be on the hospice plan of care, where the nurses will work with the staff. But besides the keeping skin meticulously clean, it's also turning and positioning.
As residents near the end of life, often diminished mobility will be a concern. There's much that we can do as caregivers to keep our residents comfortable. Know how to use the equipment well that has been provided for your resident. Perhaps instead of a standard wheelchair, your resident now has something more like a Jerry chair that provides greater support. Know how to use it and position it properly. You may also be using bed rails now as permitted according to your state guidelines in keeping your residents safe and comfortable in bed. Perhaps nothing is more important than a good turning schedule. Think for yourself. Have you ever awoken during the night and you've been in one position for a long time and oh, your muscles will just ache and you feel so uncomfortable? You can actually have pain develop where you've been laying in one spot for some time. Now imagine your resident with a terminal condition that is forced to lie in one position for a very long period of time. This can cause tremendous discomfort, so a good turning schedule is essential.
Minimally every 2 hours, the resident needs to be repositioned. But when you're looking at very end of life, when your resident is actively dying, the resident really needs to be checked and turned and repositioned about every hour because they are so weak. Anytime they're laying in the same position where blood cannot flow to the bony areas such as the buttocks, the hips, the spinal cord, the vertebrae area, all these areas where we have bony prominences, there's such a high risk that the blood will not flow to them. The resident can break down quickly. They can break down within a matter of hours right before your eyes. So cleanliness, turning and positioning, preventative care. When you're turning a resident, make sure his ear isn't bent over. These little things sneak in, and when you go to turn him back, his little ear had been bent over, and then you have a skin break.
Your resident may also use special mattresses such as air flotation mattresses or pads. Again, make sure that you've consulted with your supervisor or hospice nurse regarding the use of these items. Sometimes putting sheets too taut around such devices can impair their use, so make sure you know how to use them appropriately. We always want to make sure that we're keeping the resident's bed neat and clean. Something as little fold or a bump or a crease in the linen can cause tremendous discomfort, so we really want to make sure we're using good bed making skills. You may find that it's necessary to change your resident's linens more often because sometimes people are perspiring more and soiling their linens more often.
So when you turn your resident, turn him, check him, make sure everything is perfect. A pillow between the knees, a pillow between the ankles, shoulders are nicely positioned, and then check him every hour minimally, turn him every 2 hours minimally.
When working with a hospice agency and the resident's physician, oftentimes a variety of medications will be prescribed for your resident. Some of them will be opiates or narcotics. Some medications are designed to curb nausea or discomfort. Many medications are designed to make sure that your resident is not suffering or in pain. Make sure you understand the use of these medications if you are working as a med aid and following the doctor's orders exactly. Sometimes people become afraid about using pain medication. They think, oh, you know, this is like a drug addict. I'm giving too many meds. While certainly we never want to over-medicate a resident, in the same breath we want to make sure that our residents are comfortable at all times. Some medications will still be given orally. You may find that your hospice nurse may administer meds a different route. Many of the meds used in end-of-life care will simply be placed under the tongue, known as sublingual medication. You may also have some residents that will use a patch that will help control pain. Again, make sure you clearly understand all of these physician orders so that we keep the promise to our resident that they won't die in pain.
I was very concerned with Mom nearing the end that she would suffer. I had always promised Mom I would keep her out of pain. And they were very in tune to the fact that they watched for any signs of pain and dealt with it before it became too big. And I was very grateful for that because you seem to be guilty about everything when somebody's dying, your loved one, you worry about everything. And to have them be considerate of the fact that we really wanted to make sure she wasn't in pain was just very relieving.
One of the most important aspects of end-of-life care and comfort care is the actual pain management issues that our residents depend on us taking care of. The hospice, the caregivers, and the family, and the resident, if he's able, will formulate a plan of care. The doctor will give the orders for the medications that are necessary. The hospice will do the teaching and support the caregivers. the family and the resident in being assured that their medications are given properly and timely. But again, remember, as caregivers, you are the eyes and ears for the resident. If he is uncomfortable, he may not be able to tell anyone, especially if he has dementia or if he's just very ill and not up for talking about where he hurts or what he's feeling.
Although a resident may not be able to express themselves regarding their comfort or discomfort, in fact, even pain, there are obvious signs sometimes that a caregiver can certainly become aware of.
There are some very clear symptoms that we should always be looking for with our residents. One is any change in behavior. If a resident is agitated or irritable, he very well may be in pain. If a resident is sitting in a different position than he normally would, seeming to favor one side or another, or not as active as he normally would be, wanting to stay in bed when he normally gets up every day, very good sign that he may have discomfort. He may be grimacing or moaning, scrunching up his face, doing different looks on his face that he normally would do. He very well may be in pain. If he's breathing fast, a resident who is alert may be guarding and breathing a little bit fast, holding his tummy and breathing a little bit fast. Or a resident who is non-responsive in the bed may be breathing faster than what we would expect. A good rule of thumb is anyone resting, breathing more than about 18 breaths a minute, maybe 20, they are probably having discomfort. So when you see your resident who is alert, acting differently, acting irritable, guarding when he sits down, favoring a certain part of his body, he very well may be having pain. When you have a resident who is bedbound and not alert but is breathing greater than 16, 18, 20 breaths per minute, he very well may be having pain. Grimacing, sweating, these are also signs that the resident may be having pain.
Their response to your touch, physical movement, for example, would be a way to gauge if that resident is experiencing any discomfort. Sometimes you'll see grimacing on the face, you may hear a moan, or you may hear a voice that perhaps you didn't hear before, which could indicate the resident is uncomfortable. And certainly the common things we look for, having smooth sheets if a resident is remaining in bed, making sure the resident becomes repositioned after 1-2 hours and they're not lying in the same position at the same time. These are all typical things we'd still want to follow even if the resident was engaged in the dying process.
One thing to remember is that frequently the resident will have his own words for pain. One nurse I know said she asked a resident if he was having pain, and he was doubled over. And he said, "No, I'm not having pain. My stomach just hurts, that's all." So we have to remember that we all have different words that we use. So sometimes we need to change the plan of care. We don't ask the resident if he's having pain. We say, "Are you having that cramping feeling? Are you having that burning feeling?" So if we can figure out what word the resident will use to describe his pain, then we can use that word to ask him. But if he says no, and he still looks uncomfortable or something is not quite right, call the hospice staff and the hospice nurse will come out and evaluate.
She couldn't communicate, but she still had eye contact. So basically we would ask her if she was hurting, blink 1 time. If she was thirsty, blink 2 times. So, I mean, her mental was still there. She couldn't verbalize what she wanted. And she kind of mumbled, and you could tell when she got frustrated. But the blinking of the eyes, they still have that sensory, and sometimes that's the last thing to go. And Mom basically could tell us when she was hurting. And you could also tell by facial expression and tenseness in the body. There's lots of different ways to tell. But Mom's big thing is she kept for a long time. She could do the eye blinking. Or sometimes she could squeeze my hand or theirs. And we just kind of kept working to see what was still working with her at the right time.
If the resident is declining, he doesn't wish to take his medicine, the nurse from hospice needs to be called right away. It's important that the medications be given on time and routinely as ordered, as on the plan of care, so we can always stay ahead of the pain. That's the key with pain management, is staying ahead of the pain. If, though, the resident is having difficulties or discomfort in between doses of pain medicine, the hospice nurse needs to be called, because we very well may need to adjust the dose. It's very possible that the current dose that is ordered is no longer appropriate and we need to increase, and that's absolutely fine. The hospice nurse can come out and evaluate the resident and call the doctor. There are many non-pharmacological aspects of pain control. There are many things we can do that are not medicine, that are not pills. Caregivers can make a difference in the comfort of the residents. Little things like positioning, making sure the resident is comfortable in his chair, in his bed, repositioning the resident a minimum of every 2 hours, if not every hour, once a resident is bedbound. That will help with comfort. A cool cloth on the forehead, a fan in the room, fresh air in the room, light music, or music that the resident enjoys, whatever the family can share that was something special for the resident. We also can try very soft touch, very soft massage, maybe some lotion to the hands and feet, maybe some lotion to the back, nice odors, maybe some nice potpourri in the room, something to help make the room a little bit more comfortable and pleasant for the resident. Again, it's the communication factor, asking the family, what does your mother like? What soothes her? A little television show low in the background that she enjoyed might get her mind off the pain. Repositioning her with her special pillow that they forgot to bring from home, but they thought of it after you asked. What was your mother's favorite comforter? Did she have a favorite pillow that would help her get comfortable on the couch? Asking those questions can help make a difference with the resident's comfort.
As our resident becomes bedbound and unable to leave their room, it's important our resident never feel isolated or alone. We don't want our residents feeling bored either. Some residents become bedbound while still very mentally alert.
What was really nice is they took the time, rather than just let Mom lay in her bed and die, they still tried to make her a part of the community or give her something nice to do and not just lay there. They would bring in things for her. They would come in, or one would come in and take the time to talk to her for a few minutes and just take 10, 15 minutes and sit there. And I'm sure that they were very busy, but they did it anyway. And of course, they had a TV in her room, and they'd come in and ask if she wanted to switch stations or if she needed help doing that. She liked to read a lot, so they would make sure her books could be propped up right to where she'd be comfortable with them, and her lighting, and kept the windows open for cheerfulness, sunlight.
Here are some ideas when you have a resident who is bedbound that may assist with making them still feel part of the community and connected with others. Have a nice comfortable chair or seating in the room for others to visit. Encourage your care colleagues to come into the resident's room and sit and talk with a resident. Not just caregivers. Maybe there's a favorite maintenance man that works in your community that resident used to love conversation and spending time with. Encourage them to come visit. Maybe it's a food server that they especially liked in the dining room. Encourage them to come visit and talk for a while as well. Now remember the fatigue factor. We don't want to overstress our residents by having too many visitors, but at the same time, a friendly pat on the hand and pleasant conversation can be wonderful for our residents to enjoy. Don't miss an opportunity for beauty that surrounds us. For example, if your resident happens to be awake very early in the morning just as the sun is coming up, pull up the blinds so the resident can see the sunrise. Open curtains and blinds throughout the day so that your resident is able to enjoy scenery out of doors. You may even want to slightly reposition the resident's furnishings in the room so they have a nice view of out of doors. You can place bird feeders right outside of the resident's window to attract wildlife so your resident is able to have a change of scenery simply while lying in bed. Place patio plants and other potted plants perhaps up on pedestals or up on bricks so that the residents are able to have a nice view of those out of their bedroom window. Don't hesitate to use television or radio as long as your resident is enjoying it. Some residents find television to be a great distraction from their discomfort. Tactile stimulation can also be helpful to the resident. Placing nice soft afghans over their bed or extra comfy soft pillows for them to prop their arms on and so forth can be very comforting. Many of our residents love pets and children. Now, while this sometimes can be overtiring for some, many residents still very much enjoy having pet visitors or small children come and visit them as they become bedbound. An animal can also provide a sense of soothing comfort to the resident. So if you have a facility cat or a facility dog and the resident enjoys the visit, there's no reason they still can't continue that practice even though they've become bedbound.
End-of-life care is appropriate for residents with dementia also. Dementia, especially Alzheimer's type dementia, but there are many types of dementia, will eventually have a terminal prognosis. When the doctor deems that a resident is in the terminal phases of a dementia, he or she will give an order for hospice care. How can we tell when a resident is at the end of life stages of dementia? There are some very clear guidelines that Medicare has stipulated, and they're very useful. A resident who is at end of life stage of dementia, i.e. the last 6 months or so, based on if the disease runs its course, will have signs and symptoms such as they will be dependent for many, if not most, of their ADLs. And when we say ADLs, they're activities of daily living. Their dressing, of course their meal preparation, they may need to be fed at this point because they can no longer feed themselves. Your resident will also be incontinent when he is in the terminal stages of his dementia, and he will not be ambulatory. That is a very clear sign when someone is in the last stages of his dementia. But also there's something called comorbidities. Comorbidities go hand in hand with the signs and symptoms that we see with your resident. Your resident will become frail and weak. He may have problems with skin breakdown. He may need to be seen in the emergency room for pneumonia, bladder infections, also known as UTIs, urinary tract infections. The resident will be very confused in this end-of-life phase and need to be watched almost constantly because he is so weak.
When we talk about end-stage dementia, what we're really talking about is dealing with the process of dying. The resident typically becomes more removed, less interactive with others, and eventually may become a bedridden patient or resident.
When dealing with dementia, one of the most important things to remember is that the resident is dependent for all of his care. He cannot cognitively tell you what he needs. He cannot ask for his pain medicine. We have to look at his signs and symptoms. How does our resident with dementia show us that he's uncomfortable? How does he act when he's not feeling well? When you have a resident with dementia and he has a day where he is agitated or irritable, that very well may be a resident who's not feeling well. He may have a little bladder infection, constipation. He may be running a small fever. When a resident with dementia has a change of condition, the hospice should be notified. They should be called and told that this resident is more agitated today. He is more confused today. We need to have the hospice take a look at the resident and make sure there's not a problem that needs to be attended to. So one of the major differences with a dementia resident is they are so dependent on all aspects of their life. They are at a very high risk for injury, for falls, for things that you may not think of. They may put their hand in a door jamb and accidentally hurt their fingers because they forget or they don't have the ability to watch out for their own safety. So we need to watch out for their safety and anticipate their needs.
One of the things throughout the services provided for dementia residents is caring for the family as well as the resident, sometimes even more time spent with the family than with the resident. We have to remember that dementia care is a comprehensive care service to the family, to the resident.
Now, when it comes to end-of-life issues, the very end-of-life issues for your dementia resident, you're going to see very similar end-of-life physical changes. Your resident will become bedbound, slip into a semi-coma state where he's not very alert. He won't be able to eat or even drink at end of life. Again, all very similar situations to what you see with your residents with other diagnoses. What should the caregiver expect to see when a resident has passed away? What are some of the signs and symptoms of death? It's very simple. Your resident is no longer breathing. There is no pulse, no blood pressure, no heart rate at all. Your resident will have a grayish, pasty look frequently. And the eyes may be closed or they may be open. Usually they're just a little bit halfway open. The jaw will be relaxed. The mouth will be slightly open. And sometimes the resident would have been incontinent right before death had occurred. This is not an uncommon finding.
Once life has ceased, we will want to make sure we provide good post-mortem care, that we maintain the resident's dignity throughout this entire process. The body must first be pronounced. Now, this may take place from your hospice nurse if she is on site, or paramedics may be necessary to confirm death. Always follow your facility protocol. Once death has been pronounced, you may perform simple post-mortem care. Post-mortem care often begins when the nurse removes any medication patches, oxygen tubings, and other medical apparatus from the resident. You will want to cleanse the resident. Often as people die, they pass feces and other fluids from the body. So gently cleaning the resident, making sure that the resident is odor-free. Change any linens as necessary. You may gently close the resident's eyes, if desired, and place their jaw in an appropriate position. Sometimes as residents are dying, the head of the bed may be somewhat elevated, and you can lower the head of that bed so that the jaw will lie in a more natural position. Place a clean blanket and appropriate linens over the resident. Some find it very nice if you will place the resident's hands and arm outside of the blanket. That way, when others come and sit next to the bedside, they can easily hold the resident's hand. If the weather is appropriate, open the windows and allow for fresh air. Make sure there are no noxious odors. If necessary, use a room spray. You'll also want to make sure lighting is appropriate. Turn on the bedside lamp. Don't make the room completely dark, so that when visitors come in, they'll feel comfortable. Always be aware of residents' religious or cultural practices. For some, we are never to touch the body after the point of death. So you will only want to perform this type of care with appropriate permission. Make sure that there are comfortable furnishings next to the bed so others can sit down if desired. If the family is present, do as much as you can to make the environment comfortable for them. If you have, for example, a cordless telephone that you can offer the family if they need to make telephone calls, offer them something to drink or eat. This may have been a very long day for the family. Remember, your reassuring nods and gentle touch and expressions of concern are so supportive to the family during this period. Never judge others if they do not wish to come see the body. Some people simply are not comfortable with that practice, while others may find it very necessary. So before the body is transported to the mortuary, you may see that some family members will insist upon getting to your community and saying some last goodbyes. Remember the other residents in the community. Oftentimes they are aware when someone is terminal, and they wish to say goodbye to their friend as well. Sometimes we think, oh, that's too hard on the other residents. They'll never be able to handle this. And oftentimes we find that our aged residents actually handle this process sometimes even better than we do. So if another resident desires and is capable and safe to say goodbye to another resident, certainly escort them and allow them to do so. Take care of yourself. As caregivers, you can celebrate the joy that you have assisted this resident in this process. Your outstanding caregiver skills have allowed this resident to die in peace, with comfort and dignity.
And remember also, our residents become our families. And during the dying process, we ourselves are going through the grieving process. If necessary, seek counseling services that are sometimes and often provided on the facility level. Make sure you talk about and express your feelings to your fellow caregivers and share your love of the resident with the family. It is comforting to the family.
You are so admired and respected for your skills. After viewing this video, I hope that you have gathered some ideas and thoughts about providing outstanding care to residents with a terminal diagnosis.
Taking care of people who are at their end of life is such a privilege. It's such a special time. It's such an intimate time. And to be able to step into that journey with the patient, with the resident, with the family, can be an embracing, warm, enlightening time. It can strengthen us as caregivers. It can give us an insight to our own fears, our own anxieties, and we can grow as caregivers, as people, when we walk the path with someone who is dying.
If I can tell caregivers one thing, is to remember, if they could always think, put themselves in the place of the other person, rather than thinking of what they need to do, or I've got to do this, got to do that. Remember that what they do in life to these people as they're dying has an impact on everybody, and the dying person also. So if they can just step out of their own life for a minute and just remember that they're having an impact on this person.
As you face the challenge of caring for these residents with special needs, do it with pride. Know that the soft sound of your voice, your gentle touch, and your outstanding care practices really do make a difference. Much success to you as you care for your residents.